essentially, this is how I generally like to discuss it when I'm asked the question, why are you on social media? Why should I be on social media? Really, it has enabled all of us to make this very big world quite small, because it has allowed these connections that transcend borders, like physical borders of institution, community, state, and nation. And the more important aspects are, it allows the communication and engagement beyond your peer group. And I think the opportunities to engage both patients and caregivers and advocates, no matter what our medical field, in a safe space to connect, learn, as well as teach each other, is actually one of the strongest reasons to be on social media. And as we all know, because you're all joining either on Twitter, on Clubhouse, on on many forums, but communities can be focused or narrowed or broadened based on what one wants to do in social media. So again, this whole notion that we need to operate within our spheres, that is completely not the case today. And as I'm going to show you, the work of Cosmo has illustrated the possibilities. Now, the other thing that I think is important to note as we get into this is that social media is starting to matter. It does matter. I write a lot of letters for promotion in academia, and I read a lot of letters of reference for people looking at jobs in industries, as well as promotions outside of the academic world. There are these efforts to try to define novel metrics to describe your output on social media. I'll touch on these three for now: the social media impact score, the healthcare social graph score, and then the Kardashian index. The social media impact score actually takes altmetrics, but really was trying to harness the specific aspects within altmetrics that would be more useful to describe output. So they did an analytic data set looking at articles published in high impact journals in 2015. And then they looked at a validation data set. So they created their model using the articles from 2015, and they validated with articles in 2016. Here in the asterisk, you'll see what goes into the altmetric, and it's far beyond PubMed citations. You're talking how does your publications appear in YouTube, in blogs, Wikipedia, far more than what would be considered traditional scientific sources. What they found was they were able to sort of harness altmetrics into a score that potentially was more useful. So what they found was, when you publish an article, the coverage plateaus in about 2 weeks. And they got a median altmetric score of 72, a median score using social media at 47.8. Ultimately, the validation set, and if you wanted to know which journals they looked at high impact journals. And when I was up for promotion as an assistant professor, I asked, how many papers do I need? Well, the answer was always, if you publish in Cell and New England Journal of Medicine and Nature, you need 3. If you don't publish in those worlds, you probably need a ton more. So this is why they chose these journals. But the social media impact score significantly associated with the citation counts. So again, it's showing that not all of social media is important, but there is a subset of activities on social media that can be harnessed, and it seems to correlate with how frequently you're cited, and it even outperformed the altmetric score. The other thing comes from Simplor, and as a disclosure, Auden Utengan, who helped found Simplor, is a founding member of Cosmo. But Simplor has a proprietary algorithm that gives you a healthcare social graph score. It's an algorithm that measures the info people and the importance of content in data sets and parameters around medicine. This is the distribution of healthcare social graph scores among everyone who self-identifies as a researcher or as a physician or some other professional. Most of us probably fall on the order of less than 30. There is a very, very small subgroup who have healthcare social graph scores over 90. Now, what does this mean? Can you put this on a CV? Can you put this on a resume that your social graph score is, 70, making you, less than 5,000 people on Twitter have that kind of graph score? This is a very preliminary data set. If you see, Auden Utengen was one of the authors here, but what they did was do a cross section of healthcare social graph score and the H index, which we get on Google as a measure of publication records. What I thought was striking, that 75% of everybody with a healthcare social graph score also had a concomitant H index. And what they saw, although it was a weak correlation, your graph score was weakly correlated with the H index, which suggests a relationship between influence and productivity. So what does that tell us? It means that potentially, if you're a researcher, if you are a publishing person, that your activities on social media may be complementing your work, and that they actually may be feeding each other. How could this possibly happen? Collaborations that bear out on social media. The concrete ways I might explain this, novel associations, and there's a really great example of that that began on Twitter, and it's the COVID-19 and Cancer Consortium, born out of one tweet. People, really love the idea, and it is a consortium that is putting out high-profile papers in the oncology space around issues related to COVID-19 and the impact of COVID-19 on hematology and oncology and our patients. This is the flip side of academic metrics. This is the Kardashian index. It was by Hall. It's now, fairly old. It's almost 10 years old, but it measures a social media profile against a publication record. And it shows that there are folks who are famous just for being famous, that are people out here on social media who are not experts in anything that you can measure: publications, citations, academic output. They are literally famous for being famous. And what I think was interesting about that Kardashian index, according to Neil Hall, was he made this comment about gender in the Kardashian index. And in his analysis, very few women had a highly inflated Twitter following, while most had fewer followers than would be expected. Hence, most Kardashians are men. It does not prove we are continuing to ignore women, or if women are less likely to engage in self-promotion, but it is consistent with either or both of those scenarios. So again, the Kardashian index actually may also be a reflection of implicit bias in a strange way within professional circles. So this has been my recent experience, because I do write a lot of letters. I write a lot of letters of recommendation, but also letters in support of promotion. And the question is always, when I look at it, how are they going to count social media in terms of the promotion package? And what you're seeing here is a fairly recent paper in 2021 in the Journal of Family Medicine. 8% of institutions explicitly endorse social media activities as part of the package for promotion. 36% explicitly do not count social media. And then 40%, it's not technically stated. So this is the figure. It's 8% of institutions have welcomed, embraced, want to see social media, and want to see it counted. This figure is likely to go up, but what I will tell you is that when I do write my letters of promotion, even if it's not requested, there is always a place for us to expand on your characteristics as a candidate, whether that be for a new position or an academic promotion. And the way I phrase it is up here. It matters as a non-traditional academic productivity. So again, if you are starting your career, if you are in junior faculty positions, this can matter. It just depends on how you account and accommodate them on your CV. So let's go beyond social media. Let's think about other things, about Twitter. This is a fairly old slide now, but TikTok and Clubhouse are part of the lexicon. I know we are streaming on Clubhouse. I have yet to really discover Twitch and Discord for medical purposes. There are several folks, though, who are on Twitch and carry on conversations. The really important thing is that I do not believe that the people you're talking to are on all of these platforms. So the benefit of exploration is seeing if you can reach an entirely different demographic. And that actually has been one of the most interesting things about my being on TikTok. So brief history here, it used to be Musical.ly, and then it was acquired by ByteDance. And as of November of 2020, had over 800 million views per month. It does allow kids to join. And if you do join as a young child, there are limits placed on what you can see. The algorithm is something that people still try to crack, but essentially it's user interactions, video information, the device type. But what's not using the algorithm is your follower count and a prior history of high performing videos. Now, why do I bring this up? It's because TikTok came in very early during the COVID-19 pandemic to support science and healthcare communication. So they really wanted to support frontline medical workers in creatively teaching people about how to use this algorithm. And we learned something from that. So this is a paper from 2021 that looked at the analytics from TikTok's Creative Learning Fund. It was very small, it was a 40, but there were several types. There were, lectures that went beyond 30 seconds. There were quick facts. And then he categorized these videos that showed something being done, an experiment, experimentation videos is what he called them. And he tracked how they performed. So in terms of likes, so how many people liked what, the experiment showing something being done produced more likes. But long lectures, if you're saying something important, people tended to stick with it. The views, however, were significantly in favor of the experimental videos. So doing something active in a TikTok was more likely to get views. But in terms of likes, there was not a significant difference. Now, if you look at shares, so how many people are sharing things? So, because you can take that TikTok and share it among friends, long experimental videos. But the thing that I think is interesting, depending on what you're doing with this, if you want to get a lot of likes, you want to entertain. If you want to entertain, you tend to want to dance, you want to create, cook, you want to show something. But if you want to engage, I think this is interesting. Saying something and taking the time to say it. 60 seconds, TikTok now allows even up to 3-minute videos. That induced more comments. So this is where I think the engagement for me is interesting, that if I can create these longer lecture style videos, I can engage with more people in a way that I think is productive for both sides. Then finally, in terms of watch time, so I think it's interesting. Most comments came with the long videos, but in terms of flipping through TikTok, most people stayed and watched the end of those short, less than 30-second videos, up to 15 seconds. They tended to watch it, and they tended to watch it more often to the end compared to long experimental videos. But again, if your goal is to get everything across, do it less than 30 seconds. But if your goal is to engage people in a conversation, in a debate, in something that's in a timely social event, long lecture styles might not give you the watch time to the end, but those people who watch it are more likely, it appears, to engage with you. So neither, again, in terms of, so how does this all feed in? I'm going to skip that slide. How does this all feed in to social media in oncology? This is the introduction then to Cosmo, which was the collaboration for outcomes using social media oncology. This was the genesis off of Twitter. It was literally a crowdsourced collaboration. I was placed in charge of a committee at the American Society of Clinical Oncology. I think it was in 2015. That's when I joined Twitter. And I found other members of ASCO on my committee on Twitter as well. We decided to produce a paper because there's very little guidance back then. And I can't believe I'm saying that now, back then about using social media and what the institutions were saying about you being able to use social media. So we wrote a paper, and then we started meeting other people in this space who were doing tweet chats around breast cancer, around gyn cancer. And we all got familiar with each other without ever meeting each other. And we ended up starting to publish together best practices, the how to do it, healthcare hashtags. And because we were publishing quite a bit together, we decided to sort of, quote, formalize this into the collaboration for outcomes using social media oncology. Our objective was not to promote social media use and convince our colleagues to join social media. Our approach was to provide an evidence basis on what's possible, what didn't work, provide guidance, and then educate people around the options for social media, really trying to push the envelope to some sort of an evidence basis on why social media should matter in oncology. This is the founding members. I like to put this up because honestly, none of us met each other in real life. In fact, I'm looking at this list. I think I have met everybody on this list already, but it took about 2 or 3 years. Patricia Anderson is a librarian from the University of Michigan. Deanna Atai is a breast surgeon at UCLA. Michael Fish is a medical oncologist out of MD Anderson. Heather Hilton is a physician assistant who I met when she was at Sloan Kettering. Radiation oncology with Matt Katz, medical oncology chief of medicine at University of Florida. Bob Miller runs CancerLink at ASCO now. Nate Pennell is a lung oncologist at Cleveland Clinic. Lydia Shapiro heads survivorship at Stanford. Mike Thompson is now at Tempus, and Alden, who helped found Simpler. A very diverse group of people, really spanning the United States. We were funded for our first meeting in 2020, and we actually were able to successfully get funding through the NCI's R13 mechanism. It was jointly funded really by Stanford and the Lifespan Cancer Institutes, with money and CME support coming from Brown. Our ideal vision was going to be to have this as a live meeting, but as we all know, COVID happened. So this meeting became virtual, and we held it April of 2020. Is that right? April 2020? Yeah. This is the content we covered for this meeting: social media and oncology and professional development. And it was actually a combination of very short didactic lectures, about 20 minutes, but then a ton of panels, stakeholder panels, where we got Cosmo members, and we invited, patient advocates. We invited folks who were not on social media. We invited people involved in the equity space and people involved in professionalism. And this is what we covered during that time. We had virtually over 230 people attend the virtual 2-day meeting. The predominant were nurses, and physicians made up the second largest group. Administrators and researchers also joined us, as well as advocates. But I was literally surprised by who joined us for the virtual meetings. And the conversations were really quite significant during that time. This is what's come out of the meeting, going now a year later. We have published these papers out of Cosmo. And I'm going to note a couple of things. If you look down this list, it is not led. These are the 4 original papers. The founding members are not first authors. Indeed, Anusha Chirdarla, Andrea Nampa Guzman, Eleonora Teplinsky, Narjis Duma are either medical students or junior faculty. And in the case of Dr. Chirdarla, was going into her fellowship when she volunteered to write this paper as first author. And we got this incredible diversity of authors. All of these 4 first authors are women. They were all Senior authored by a founding member of Cosmo, Heather Hilton, Lydia Shapira, Stephanie Groff, Mary Jennifer Markham, and Mike Thompson. But these are all original contributions to the medical literature, and they were accompanied by 4 editorials. So Dr. Atai and I wrote about social media oncology, The Time Is Now. Doctors Loeb and Malik wrote about methodologies. We had a paper about ethics, again, a junior investigator, and then Dr. Subai and Gruwell really opined about a regulatory framework for social media platforms in healthcare. And then we had this one paper that was outside of the JCO oncology practice, which these 8 were, and it was led by Dr. Ponce, who's a radiation oncology resident, about netiquette for social media engagement in future oncology. So we were able to turn the output of this meeting into tangible papers that have seen publication. So in addition to the 230 people who joined us during the virtual meeting, we had a very large presence on social media, mostly on Twitter, because that's where Cosmos started. So in terms of the 2-day experience, and you'll see it, really seen on the Twitter activities, it was really in 2 days during the meeting, we saw a lot of Twitter activity. 2,000 tweets, 1,400 retweets by 300 users on Twitter, and 20.7 million impressions. Now, these labels here of doctor, advocate, researcher, academic, individual, other health, investigator, this is part of the algorithmic way that Simpler categorized people. I can tell you, you could be a doctor, and you could have clinical trials. And if they were able to find your trials in clinicaltrials.gov, for example, you were classified as a researcher or academic. Otherwise, the label associated with your Twitter account came from your description of who you were. This is the general meeting that we had. Most of the talk on Twitter was around social media. This was the most common term used. Cancer experience, patient engagement, communities also came up. And I just love these sort of interactions here. And if you can see, most of these folks who are the bigger bubbles are our founding Cosmo members, but not everybody. We had Dr. Chapman, who's a radiation oncologist. We had Dr. Chino, who does a lot of work in financial toxicity. We had Devin Carter, who is from MD Anderson. We even had a research foundation as well. Janet Freeman Daly, a huge advocate in the lung cancer space. Dee Sparacio, a huge advocate in gynecologic oncology. And then some folks who were finding Cosmo for the very first time, like Dr. Saeed here. We were also seen, and we had people joining from across the world, not a huge numbers, but 11 people joining from Europe was pretty exciting. And we had coverage across the United States in terms of the coast, but also in the center of the country. In terms of the major themes, I thought this is also interesting. We talked a lot during our meeting about the dangers of social media. And if you can see here, misinformation comes up multiple times. Social media, and it was, a lot of this was driven by our keynote speaker, which was Dr. Sylvia Chow Wen from the NCI, who gave a fantastic talk about misinformation on social media, generated 1.1 million impressions with 149 original tweets during the meeting. We also talked about patients as experts. I think this is fascinating in terms of the words that were used: patient engagement, privileged, expert, panels, social media, doctors. Not a lot of variations in terms of the words that were being looked at on this topic of patients as experts. Smaller amount of tweets and users, but still over 300,000 impressions with that theme alone. We also covered diversity, equity, and inclusion. As you can see, a huge variation in the word bubble that was produced through the analysis in terms of coupling equity and diversity in terms of diversity by itself, in terms of the cancer experience, in terms of equity uncoupled from diversity. Again, Dr. Chapman was a member of the panel talking about diversity, and social media is right here as well. So 105 tweets on that. And again, a pretty large impressions with the theme of equity and inclusion. So what I think I'm demonstrating for you is that it's another way to look at the output on social media from a conference about social media, because I think what we're pushing ourselves in Cosmo to do is provide more of a description of what is actually covered rather than the overall impressions that were generated from a meeting. So what's next for Cosmo? We're doing new projects. We actually have 2 projects that are being done as surveys. One is around the imposter syndrome and the experience on social media with it. And the other is looking at the experience of burnout and whether or not there is an association, not causation, not correlation, but whether there's an association with social media use and the experience of burnout among clinical trialists in both the pediatric and the adult space. I showed you all of those papers that we published out of the first meeting of Cosmo. 8 of those will be in a print special issue on social media in the JCO Oncology practice, of which I was fortunate enough to be the guest editor for. So in conclusion, social media is really an integral part of communication today. I think you don't have to join it, but I think you ignore it at your own peril. Most patients are looking up their doctors, and that is a fact of life today. I don't think I go through a clinic where new patients do not tell me they Googled me. And the thing about being Googled by people who are seeking your opinion is that if you do not control what appears on Google when you are searched, you are ceding a huge part of what people discover when they look for you. And I think that is a really important thing for oncology and medicine professionals to understand. You have the ability to craft your brand. And I mean brand in a very loose way, but essentially I want you to think about Google searches as someone looking for your brand. And if there is nothing found on you, then it's unclear how that is interpreted in today's climate. With a social media presence, with the ability to craft who you are on social media, whether that is taking advantage of Google Scholar and filling out your CV, whether that's looking into and joining Doximity as an active user, whether that's even going into your institution or your work page and actually taking the time to fill out that About Me page. All of it counts. And to not take advantage of those things, it can come at your peril. Most people who see me as a new patient today, I can tell you God's honest truth, have a sense who I am as a person. And that sense of familiarity, especially when we are treating cancer, is golden, because I don't have to deal with the discomfort of not knowing who they are speaking to because someone has discovered me in their immediate circle. And it can be as significant as, oh, their daughter is on TikTok and found you, or it can be, oh, I follow you on Twitter and I know what you post. There is that bidirectionality though on social media that I think is exceptionally critical to understand. Those of you on Clubhouse take advantage of that bidirectionality when you put people on stage and you have conversations with people. That's really critical on social media platforms for professional use. People can sense when you're not being authentic. People can sense if your tweets are coming from a professional social media manager, because what they want to see is engagement. So if they say something on your post, they would like to hear something back, particularly if it's a question that's coming back to you. So again, going to this idea of all of us having a brand, it's something that we need to really cherish, and we actually have to feed. The benefits of it, especially for professional social media use, is that it does open up collaborative experiences and opportunities that you would probably not get otherwise. Again, Dr. Chadarla and I met for the very first time in Chicago at ASCO. This is after a 1-year journey of first draft and 2 other revisions with JCOOP to get her paper accepted. And that amount of commitment to mentorship was only possible because she attended Cosmo and volunteered to write a paper for us. For all of us, whether you're oncology or some other field of medicine or just starting out in this field, just recognize that social media activities are what you plan to make of it, but they can be exceptionally relevant and worthwhile. If you look at Sarah Beltran-Ponce's paper on netiquette, I am frequently quoted as saying, you don't post when you're very tired, very drunk, or very angry, because those are the situations when you're tweeting through your emotion, is when you likely could get in trouble. Otherwise, being deliberate on social media is important as a professional, and that deliberateness is what people will likely respond to. And then finally, for all of you out there listening to this talk, Cosmo is, again, a crowdsourced forum born on Twitter, which has been semi-formalized. We don't have a fee to join. There's no membership application. Literally, if you want to learn more about us, just email me or talk to somebody in Cosmo, like Dr. Leafman, and get an invite to the meeting. It's usually open. And we welcome collaborations. And the reason we're here is we really want to push forward projects. We want to look at the novel ways we can harness social media, whether that be in clinical trial accrual, completing the clinical trial circle so that people understand the results of the trials they were in, or even addressing the workforce issues that we all deal with in the clinical trial enterprise. There's so many questions we could ask with Cosmo. We want to be the resource to help you get your research done.